So I have kind of a funny story that I would like to share with you about one of my memories of a patient who had MG. So he was all of 90 pounds. He had a feeding tube. He was extremely cachectic looking. He was not able to speak. He was not able to walk. And one of the things I had to do for him was turn him every 2 hours. And trying to be very understanding of his condition and trying to be very, caring for him, I would go in there and just give him all of the love and the doting that I could, because I wanted to make sure he felt valued. And one of the times that I went in there to provide some kind of mouth care, he kept clenching his teeth together, and when I went to rotate him, he would sort of resist a little bit, like he wouldn't bend his knee to roll over. He would just kind of lay flat. Even though he was weak, you could tell he was resisting. And so I was like, oh, is something wrong? Something wrong? And, is there anything in particular that you want or really need? If you want to ask for something, I could give you some paper and you can write it. And so he nodded his head, and I said, okay. So I went and got a piece of paper, and I sitting here very, I'm feeling very nursey at this point, thinking like I am just providing my patient the best care ever. So he finally scribbles something, and I look down on it, and he wrote, "Go away." Oh, well, so yeah. So I looked down at that, and I was like, I'm thinking that says "go away." And he could barely move any of his mouth, but I think there was a hint of a smile. So what I did was I said, okay, I will honor your wishes for this moment, but I do have to come back in an hour and turn you, and I won't do all this busy talk. Does that sound okay? And he just stared at me, and that was the end of that. So that is one of my most prominent memories of taking care of a patient with MG. I think they've been in the hospital so long that they're over it. They're over our routines, they're over our excessive care, and that's how that goes. So yeah, his words to me, go away. Nice, nice. Let's dive a little deeper into myasthenia gravis. So we consider this an autoimmune disorder which is characterized by weakness. Initial symptoms are usually related to cranial nerves that control vision, so our patients will oftentimes report some kind of blurry vision or maybe even diplopia. There are several types of myasthenia gravis. The main ones are ocular and generalized. You don't need to know the grades or the categories of MG, just sort of recognize that you can have one or the other or a combination of ocular versus generalized MG. Now, a lot of the cases of MG, in fact, a third of them are actually caused by a thioma. The thymus gland has a role during a child in growth and development. However, after a child moves past puberty, it sort of just becomes an inactive gland. However, when we have patients with MG, it actually produces an antibody, and as you can see there on our picture, it is actually going to block the acetylcholine that is coming down and trying to nervate the muscle. That's a problem. So in a lot of our cases, if we can remove the thymus gland by doing a thymectomy, then we can actually resolve somebody's MG. All right, next point. Our onset is oftentimes insidious, meaning it's going to take years for a person to finally come forward. However, there are some cases where the onset is rapid, and it does take some really good questioning of our patient, a really good health history to be able to determine that they have MG, so we can rescue them from death. There are times of wellness and there are times of exacerbations. It's usually not a complete wellness though, there's some limitations there. Let's see, the disease is usually progressive in nature. unless you can have a thymectomy. Then it sort of goes away. We're going to see MG occur more in our male counterparts than females. It is not specific to Caucasians or African Americans or Hispanics. Any race and any age can come down with this condition. Now, what is going to trigger an exacerbation? Well, thyrotoxicosis, such as excessive thyroid hormone, is one of the different reasons. So a lot of times when patients have signs and symptoms of MG, we're actually going to grab a TSH, a T3, and a T4 hormone. Because that, if it gets fixed, because it's the cause, then we're going to solve the MG crisis that a person may be in. We're going to also have MG exacerbations due to infection, due to pregnancy, anesthesia. So a lot of times if we can family plan or maybe avoid general anesthesia, that's the route to go, because the person won't have an exacerbation then, which we will get into later what a MG exacerbation exactly is. Now, there are a few other reasons that are going to cause a transient exacerbation, such as a menstrual cycle, getting a vaccination, exposure to heat. And those reasons, they're going to have mild MG symptoms. And it usually resolves in just a little bit of time. Now, I do want to describe this very unique syndrome called Eaton-Lambert syndrome. And I actually found a really great picture of Clint Eastwood. I feel like he kind of has this myasthenic snarl that I'm going to show you on the next slide. But, you know, Clint Eastwood, Eaton-Lambert syndrome, you going there with me? Well, we're not. This is where a patient who has no history of MG develops lung cancer. And these tumors actually have a hormone secretion component to them, and they're actually going to support development of these antibodies where it's going to block the acetylcholine receptors. So then we're going to actually develop MG, but it's really the lung cancer. So what we got to do is identify that this person first has MG, symptoms, and if it's due to lung cancer, then we actually call it Eaton-Lambert syndrome. Therefore, if we kill the tumor, we give the MG drugs, MG, medications to manage it, and the tumor eventually dies or gets resected, something, the MG is actually going to go away. Kind of cool. So here are the symptoms of MG. Early on, a person is going to just notice that they're going to have difficulty chewing, swallowing. Maybe they're going to drool a little bit and their mouth is going to hang open. Their voice is going to be extremely weak. They won't be able to project, and it's going to have a nasal-like twang to it. And let me describe kind of what that means. They're going to kind of talk like this, and there's going to be some pauses to their speech. To me, in my mind, it kind of sounds like a little old grandma. All right, next we're going to talk about some common symptoms. They're going to have the signs and symptoms of bulbar involvement. The bulbar involvement means facial expressions are going to be affected, chewing mechanisms, and speech, such as dysarthria. You're going to see bulbar involvement also when we learn about the stroke section, because that's a very common set of symptoms. Anyway, we're also going to notice that they have levator palpebrae weakness, and what that is, it's the extraocular muscles of the eyelids are going to be weakened, and so now we notice ptosis. I know it looks like ptosis, but it's actually pronounced ptosis. So the eyelids can droop, either one all by itself or both of them can. And to be able to test for ptosis, you're actually going to ask the person to look up, and they are going to look up for like 30 seconds, and that is really, if they have MG, going to exacerbate the ptosis. So when they look down, you're actually going to notice that their lids are very heavy because they just did a major workout right there. All of their available acetylcholine is now exacerbated. No more receptors to bond to, so the muscles are not going to work. Our patients are going to have an open mouth appearance, so their mouth is actually just going to hang, especially when they're tired. Their mouth is going to be open. My grandma used to say, if I ever did that, are you catching flies? No, Grandma. I have MG and I'm just tired. No, of course not. You do not talk to your grandma like that. Okay, I have a picture here of the myasthenic snarl. This is one of the classic presentations of a patient with MG. They are not able to fully draw in and pull back the nasolabial folds strongly. So they're going to kind of like grin just a little bit, but kind of look like they're upset or maybe disgusted at something. Symptoms are usually milder on awakening and they worsen as the day progresses. Your patient is going to report that short rest periods are temporarily going to restore muscle function. So do ask your patient, okay, you have these symptoms, what seems to make them better and what do you find makes them worse? And you might identify the fact that these rest periods actually do the person wonders. Now, some late signs and symptoms of MG include respiratory involvement. So a person is not going to be able to take a deep breath. They are not going to be able to cough. There's actually going to be bladder and bowel control issues, so they're going to be incontinent of both. Do note that their level of consciousness is not affected. In most cases, their level of consciousness is not affected. Once again, in most cases. Let's talk about some different ways to diagnose this very rare disease, because oftentimes diagnosis is delayed or it's missed, so it's very challenging because their symptoms do sort of come and go. I mean, did they have a vaccination? Did they resolve their infections? And different MG presenting symptoms can be less severe, so it just sort of is attributed to, oh, your eyes just a little droopy, probably because you're stressed. You know, and a person rests and it goes away. So diagnosis is often delayed, is what I'm trying to get at. All right, we can go ahead and draw a serum level on our patient and get a anti-acetylcholine receptor antibody level. However, this takes a while to get back, and it's not 100% positive that it's going to give us a true diagnosis. In fact, they say that in most cases of people who have MG, they will test positive for this antibody, however, not all. So we can't exactly rule out the condition just because they have a negative anti-acetylcholine receptor antibody test. Once again, this takes forever to come back, a few weeks. Remember how I mentioned that thyroid toxicosis can lead to an exacerbation? So let's double check our thyroid hormones to see if there's any correlation there. We can do a chest CT or a chest x-ray, and this is going to let us know if we have a thioma present. Hopefully not, but we're going to look for a thioma. We can do a repetitive nerve stimulation test. The repetitive nerve stimulation test is known as the most common test to diagnose MG. It does reveal a decremental response to stimuli. You put these little patches on somebody, you begin stimulating their muscle, and what we're looking for is the muscle to get weaker and weaker and weaker. That is a positive response and likely to lead to the diagnosis of MG. It is mainly used for diagnosing generalized MG. Now, we can do something called electromyography. Yes, electromyography. This is where we're actually going to insert an electrode into the muscle and stimulate it. That's actually my picture on the left there. I probably should mention the repetitive nerve stimulation test is on the right. Sorry about that. All right, so electromyography, insert the electrode. We're going to stimulate it. The single fiber EMG, though, it's not demonstrated here, but this is considered the most sensitive test to be able to diagnose MG. In fact, it pretty much diagnoses almost all cases of generalized and ocular MG. And what we are looking for is an increase in jitters. An increase in jitters. I know you're probably curious, well, what is a jitter? A jitter is when you compare the timing of the fire, they're firing the signal, and that delay time. If it increases, well, let me rephrase that. We're going to compare the timing in between the firing, and they call this timing the jitters. The more the jitters, the longer the time, there's a high chance that our person likely has MG. For all MGs, patients must be informed that they are going to feel a little bit of stimulation. However, it is harmless and they need to remain completely relaxed. Here, touch this electric fence and just don't move. Please don't tell them that. There's two more tests I'm going to mention here. One is the Tensilin Challenge test. Now, it's a little non-specific, but we still will do it from time to time. When I say non-specific, a lot of times doctors will go ahead and skip this test and go a little bit more to the definitive ones. However, let me go ahead and describe the Tensilin Challenge test. What we're going to do here is we are going to administer to our person Tensilin, and the official name for it is Idrophonium. I never can say that one right, but Idrophonium. So we're going to administer this medication, and we're going to do, just some very, very close observation after we administer it. We're going to notice that it's going to have a rapid onset, a very brief duration, and the person is actually going to experience strength for about 4 to 5 minutes. Their eyes are going to be able to widen more so. They're going to have much improved breathing and much improved muscle tone, and it's just for about 4 to 5 minutes, and then it's going to go away. So this is a positive response to the Tensilin Challenge test, and this lets us know that our person more than likely has MG. Now, we can have an increased number of false positives if we tell our patient what we're looking for, and a person may just out of wanting to, there's a name for it, but it's basically where the person wants to have a positive response to sort of please the tester. It's some psychology term, I cannot think of it right now, but they will actually try harder, and so we're going to have a false positive test. You're still weak, sir. You're just trying harder. Now, we can actually have a false negative test if a person is so extremely weak, or maybe they're resistant to the medication. What is important to know about this exam is that you must have the drug atropine at bedside. Atropine is the antidote to this medication. And as you're administering this medication, we're looking for increased strength, but we're also looking for somebody to, say, overdose, and they're going to have fasciculations of the face, meaning they're going to have like little twitches, and of the tongue. This is going to let us know that we have actually induced somebody into a cholinergic crisis, which I'm going to explain shortly. Okay, the last test I want to explain is the ice pack test. I know, right? The ice pack test. So somebody who has ocular signs and symptoms of MG, meaning the ptosis, the droopy eyelid, apply an ice pack for like 30, what did I read? It's either 30 to 60 seconds or like 2 minutes. I know that's a huge difference. I should probably figure that out. But yes, you're going to apply an ice pack to their eyelids and you're going to take it off. And if they notice an improvement, we probably are likely going to have MG that we're dealing with. Ice pack test. Okay, remember how I talked about the cholinergic crisis? Let me go ahead and clarify a teeny bit more about what that is. So, we have somebody present to our ER, they're in respiratory distress, they're weak all over, we notice that they have pneumonia, they have dysphagia, and they may possibly not be able to communicate with us very well because of the dysarthria. At this point, if we know that they have a history of MG, it's really hard to determine if they are in a myasthenic crisis or a cholinergic crisis. There is a difference. So a myasthenic crisis is when somebody has all of the signs and symptoms and they are lacking acetylcholine to nervate everything that they need to nervate. So there is a deficit of acetylcholine. So that's why we need to give them some more anticholinesterase drugs. So they have more acetylcholine available to them. Now, a cholinergic crisis can also result to have respiratory failure, but this is because a person took too much cholinesterase drugs. Another word for anticholinesterase drugs is cholinesterase inhibitors, which I feel like that's so much to handle. It's very heavy terminology, but anticholinesterase drugs is the same as cholinesterase inhibitors. All right, so basically what I'm trying to say is somebody comes in with respiratory distress, you don't know if it's because they're so weak or maybe they've overdone it. And oftentimes to be able to tell the difference between if they've overdone it or underdone it, with their medications, like why are they having this exacerbation? That's why we have to do the tensilin test. So we give them a little bit of that edrophonium, and if they improve, it was a myasthenic crisis. If they get worse, well, they're in a cholinergic crisis, and you must give them atropine. Well, what else should I have at bedside in the event it's a cholinergic crisis? Great question. You're going to have a BVM, a valve mask so you can breathe for them. You're going to make sure oxygen is available, suction for sure, and emergency intubation equipment, make sure that's available. And yep, that's what you need. Oh, and before you do the tensilin test, please make sure that they're on a heart monitor and continuous O2 sat. I know that's a given, but just saying. Okay, here are some interventions for our person. We're going to make sure that speech therapy is available. They're going to assist and retrain a person to swallow. They're going to, they're going to help us modify our diet. A dietitian can also probably be involved in the event that a person has weight loss because they cannot eat or find foods that they can meet their caloric needs. We're going to make sure that an OT can assist with adaptive devices and help us with communication tools. Maybe they say that nurses should ask more yes/no questions and maybe operate off of an eye blinking system. Like close your eyes very tight for no and blink twice for yes. I will say that some nurses will modify that, so that's not this universal eye blinking system. You just sort of ask what works for whatever unit you're working in. Nothing like you having a different system than the shift before you or after you. That would be weird. So if somebody is in a myasthenic crisis, we're probably going to do plasmapheresis. Now, what is plasmapheresis? This is where we're going to insert a dialysis cath either into your internal jugular vein or maybe into your femoral vein, whatever it may be, and we're going to take your whole blood out. It's going to be spun off. We're going to separate your plasma from your platelets and your red blood cell, and we're actually going to give you donor plasma. So we're actually removing all of the bad antibodies, and we're going to notice that their symptoms are going to decrease. This is kind of considered short term for an exacerbation. However, it is extremely helpful. I used to work in a unit that put in these dialysis catheters, and we actually had that patient who told me to go away. He didn't remember me. I so remembered him, but he actually came down because he was in a major myasthenic crisis, and he actually could not breathe. They were about to intubate him, and they said, please, before we intubate, we want to make sure that this catheter is in so we can do plasmapheresis for him. So yes, we're going to remove the antibodies to decrease his symptoms and hopefully not intubate, but they were actually probably going to intubate. His breathing was awful. Couldn't breathe at all, really. All right, what's the nurse need to do? Make sure to monitor the hemodialysis catheter for infection. And we're not allowed to use it for IV fluids. That is a big no-no. It is only for plasmapheresis. For airway management, we may, as I mentioned, have to intubate and put them on a ventilator. Hopefully not. If they are just a little bit weak, but they can still draw in their own breaths, well, then let's do BiPAP. We're going to put this mask over their face. They're going to initiate the breath, and then the machine is going to assist with a correct volume and rate of inspiration. Make sure to schedule activities about the time of your medication administration. There's a medication called pyridostigmine bromide, and that medication needs to be given about 45 minutes to 60 minutes just before an activity schedule. So what that means is I'm going to collaborate with my occupational therapist and my physical therapist, and I'll say, okay, I'm giving my med at this time, you come at this time. Are you going to hold this medication prior to surgery if they are NPO? Answer is no. In fact, you are going to, usually we can do this, we can give this medication with a small sip of water. Please make sure to communicate this to your CRNAs or to your anesthesiologist, to the whole surgical team, but this is not a medication that gets held when a person is NPO. Well, what if they can't swallow? We'll put an NG tube down and then administer it this way. It needs to be given. This is like their lifeline pill. If not, you're really going to precipitate a worsening of their symptoms. Can I give it IV? I'm going to have to think about that. I think we can give an IV version. Yeah, I think we can. All right, feeding tube management. At some point, they are not going to be able to swallow anymore, such as in my story, my gentleman there, all 100 pounds of him. So he had a feeding tube right there into his stomach, and he pretty much was quote-unquote NPO, but that was really only for his mouth. He could have anything and everything through his tube. And when I mean anything and everything, I mean medications, not the enteric-coated kind, because you have to crush those to get him through the tube. And we could give him water boluses and formula. Skin management, these patients need to be turned Q2. They're a very high pressure ulcer risk. You may have to pad and protect, as well as get a special mattress for them. If a person is experiencing a cholinergic crisis, please make sure to give them atropine, because in a cholinergic crisis, if I didn't explain it earlier, they're going to have bronchospasms and severe bradycardia. And we are going to make sure that oh gosh, that's what it was. If somebody is on atropine, this drug naturally dries up secretions. So we're going to watch for mucus plugs in their airway. So if they are have lots of salivation, or maybe no salivation, but if they just have, say, pneumonia, it's going to dry them up so much that it may form mucus plugs. So how do you know if somebody has a mucus plug? They're breathing fine, and then they act like they can't catch their breath. At that point, you probably need to suction and intubate. Rest is considered critical because if they get too stressed, it can actually precipitate and worsen their crisis. So we're going to make sure to administer those medications 45 minutes to an hour before. There are tons of medications that should not be administered to a patient with MG. Lovely chart that explains it all. Some examples are aminoglycosides such as gentamicin or neomycin. Even tetracyclines can tend to worsen it. Some examples are doxycycline, minocycline. Please be sure not to administer any of those classes of drugs. Now, steroids actually can temporarily worsen MG symptoms. However, we still give it and we monitor. We do need a little bit of those immunosuppressive effects. So corticosteroids basically should be on the list of what can worsen symptoms, but it is just for like a little bit. You got to weigh those benefits and risk. Antihistamines that have that anticholinergic effect. We need our little cholinergic, what am I trying to say? We need all the help we can get. So giving an anticholinergic could have some major ramifications. My best recommendation is to, if you have somebody with MG and you get a new medication order, please double check with your drug guide to make sure that is okay, because there's a lot of don'ts with a person who has MG. Okay. If somebody does not have enough acetylcholine available for use, because the day-to-day dose is going to vary. Sometimes a doctor has them taking a higher dose Monday, Wednesday, Friday, and a lower dose Tuesday, Thursday. It really just also depends on a person's needs. It's in constant flux of what a person's dose is. But let's just say that their body in that moment of time, maybe because it has an infection, needs more. So now we're going to result in a myasthenic crisis, and that's going to look like this. We're going to have tachycardia. We're going to have tachypnea, fast breathing. We're going to have elevated blood pressure, so they're going to be a little hypertensive. We're going to have poor urine output. So if we're doing our eyes and nose, we're going to notice that. There's our bowel and bladder incontinence again. And we're going to notice an absent cough and a swallow reflux, or it's going to be so weak you don't even really notice it. I think I mentioned that we're going to give, or we can do, the plasmapheresis. Another option is to use IVIG. That stands for intravenous immunoglobulin. This is used to treat acute exacerbations, or it actually can be used for long-term maintenance therapy if a person is pretty resistant to other treatments. And we're going to definitely make sure to give a person prednisone, but please remember this can temporarily worsen symptoms. And for that little picture I have here under the pyridostigmine, we're going to make sure to watch for increased weakness, which I know that's hard because they're already weak, but increase in sweating, salivation, excessive tearing, like tears in your eye, and nausea, vomiting, diarrhea. If you see those, they may have had too much of their pyridostigmine, and this indicates that they're in a cholinergic crisis. And obviously, if we're doing a tensilin test and you see all of those things, you have definitely got a cholinergic crisis on your hands. Okay, my last slide here. I know, you're at the end. We're going to have home physical therapy and a home health nurse involved in a patient's case, because they are going to monitor, evaluate, and treat the patient. We need to encourage our person to avoid crowds. Why do they need to avoid crowds? Well, they are not at high risk for infection, but if they get an infection, we're likely going to have an MG crisis. They need to avoid overeating. That can stress the body. We're going to avoid heat. In fact, patients it's a recommendation that they not take hot showers because heat actually can exacerbate MG symptoms. Not throw into a huge exacerbation, it's just a 15-minute shower, but it can actually exacerbate the symptoms. So we recommend lukewarm showers, or if they need to take a hot one, that they rest for about 15 minutes afterward because they're going to feel exhausted actually. They have erratic sleep habits, so if they can, try to take medication to sleep a little bit better. Wait, let me rephrase that. We need to avoid erratic sleep habits, and this is to reduce the fatigue that they have. Try to avoid medication. I take that back. And stress also can lead to more fatigue. So stress management, good coping skills. Everything should be done in the morning around their med times and immediately following a nap. So make sure that schedule is all mapped out because that's where they're going to have the most energy, like a battery. Because of the ptosis, we're going to make sure that they have artificial tears. At night, they're going to get possibly corneal abrasions because their eyes are not going to completely close. And that is a good reason for us to tape their eyes shut at night. I know, cool, huh? Or they can wear a very tight eye mask. But they need to make sure their eyes are tight, shut tight at night. And eye patches. That is to assist with a diplopia. It's very crazy thing to wear an eye patch for blurred vision, but believe it or not, if you have, if you're seeing double, just covering one eye for about 4 hours at a time, and then you switch it to the other eye, is actually going to do wonders, and your person can see normally. Well, I don't know about you, but somebody's excited that I'm done. Yeah, very excited actually. Whew, move on. Next topic to learn.